Hidden barriers. How class differences undermine forensic psychotherapy. Forensic psychiatry faces a structural challenge that remains largely unaddressed in clinical literature: the systematic class divide between treating professionals and their patients. While psychologists and psychiatrists predominantly originate from middle-class backgrounds, forensic patients often come from marginalized communities. This disparity creates subtle but significant barriers that can fundamentally compromise therapeutic effectiveness. The class divide manifests most clearly in conflicting communication styles. Mental health professionals typically employ elaborated speech codes characterized by complex sentence structures, conditional language, and psychological terminology. Questions like "How does that make you feel?" or "What emotions does this bring up?" reflect middle-class socialization that values introspection and verbal processing. Forensic patients, conversely, often communicate more directly and pragmatically. Their responses are frequently misinterpreted as superficial or lacking insight, when they may simply reflect different cultural norms around emotional expression and problem-solving. What appears as therapeutic non-compliance may actually represent subcultural incompatibility. This disconnect becomes particularly problematic in the assessment of aggressive behavior. In working-class communities, direct conflict resolution, including raised voices and explicit confrontation, often serves functional purposes and leads to quicker conflict resolution. However, forensic settings systematically pathologize any overt expression of anger as evidence of poor impulse control or treatment resistance. Meanwhile, the passive aggression common in middle-class communication, silence, sarcasm, indirect criticism, is reframed as professional boundaries or therapeutic technique. Patients who cannot decode these subtle patterns or who respond more directly are quickly labeled as difficult or treatment-resistant. Therapeutic objectives often unconsciously reflect middle-class values and assumptions. Developing insight typically means learning to engage in psychological self-analysis using academic frameworks. Social skills training focuses on middle-class communication norms. Anger management aims to replace direct expression with sublimated responses. These goals aren't inherently problematic, but they fail to recognize the adaptive value of working-class strategies. A patient who has survived in harsh environments through directness and clear boundary setting is asked to adopt communication styles that might be perceived as weakness or dishonesty in their social context. What clinicians interpret as treatment resistance may frequently stem from these subcultural misunderstandings. Patients intuitively sense that their authentic selves are being pathologized rather than understood. They experience the therapeutic relationship as fundamentally alienating and judgmental. The therapeutic alliance, essential for any meaningful change, cannot develop under these conditions. Instead, patients learn to perform therapy speak, reproducing expected responses without genuine engagement or transformation. This problem extends beyond individual practitioner limitations to systemic issues within forensic mental health. Training programs and supervision models perpetuate class-specific perspectives. Success metrics focus on patient conformity to middle-class behavioral norms rather than individual functionality or cultural authenticity. Clinicians, typically lacking direct experience with their patients' social environments, consistently misinterpret survival strategies as pathology, pragmatism as cognitive limitation, and warranted mistrust as paranoid thinking. The result is a system that inadvertently reproduces class hierarchies under the guise of treatment. Current forensic psychology research rarely examines these class dynamics explicitly. Studies of treatment-resistant populations focus on individual psychopathology rather than systemic barriers. This research bias reinforces the notion that therapeutic failures result from patient deficits rather than subcultural incompatibility. Effective reform requires acknowledging these class-based barriers and developing subculturally responsive interventions. This involves therapeutic humility. Clinicians must recognize the limits of their subcultural perspective and approach patients as subcultural interpreters rather than experts on their lives. Functional assessment, evaluating behaviors within their original context before labeling them as pathological. Survival strategies that appear maladaptive in clinical settings may be highly functional in patients' home environments. Expanded success metrics. Moving beyond middle-class behavioral norms to assess improvement in terms of reduced recidivism, improved life satisfaction, and enhanced functioning within patients' actual social contexts. Diverse treatment modalities, developing interventions that work with rather than against working-class communication styles and values. This analysis doesn't suggest lowering treatment standards or avoiding accountability. Rather, it calls for recognition that effective therapy must bridge subcultural divides rather than demand assimilation. Many supposedly untreatable patients may simply be subculturally mismatched with available interventions. Forensic psychiatry must confront its unconscious class assumptions. The field's commitment to evidence-based practice should extend to examining how class dynamics influence therapeutic outcomes. Until we develop truly subculturally responsive forensic interventions, we will continue to label patients as treatment failures when the failure may lie in our inability to understand and work within their subcultural frameworks. This represents both a practical challenge and an ethical imperative, ensuring that forensic mental health services serve all populations effectively, regardless of their social origin or subcultural background.